Okay, thank you so much. We're delighted to be here. I'm here with my colleague Stuart, who will introduce himself when he comes up. So we're here today to talk to you about the learning from our evaluation of the impact of video tools in digital mental health services. I think it's fair to say that we're here representing many partners. So we came together as a partnership in June 2020 as a direct impact of COVID. And the reason for coming together was to look at the impact of remote consultations in mental health. Because there'd been a really massive shift from face-to-face to remote consultations. And when we talk about remote, we're talking about telephone and video. So our organisations are the 3 South London mental health trusts, that's South West London and St George's that Stuart is representing, South London and Maudsley, Oxley's, and then our academic partners, the South London ARC, Mental Health Policy Research Unit, which is a national organisation, and King's Improvement Science. And I'm here today representing the Health Innovation Network, which is the academic health science network for South London. And the whole of our programme was informed by 4 experts by experience that we recruited to be part of this project, who had very different backgrounds in terms of their own experience of mental health and lived experience at the time. So why did we come together? What were we trying to do? So I've already said we were trying to look at the impact of the remote consultations, but we really wanted to know what was successful, what hadn't been, who wasn't being included. You know, we talked a lot about digital exclusion already today. We wanted to know what was going to be the greatest benefits for staff, patients and carers. So it was really important that we understood both patients and carers as well. And we spent a little bit of time working out what would be the way that we could possibly do this. We wanted it to be an evidence-based approach. We knew that many people were starting to look at this back in June 2020. So our academic colleagues very much looked at pre and during COVID literature. So we're looking at what was the literature on remote consultations in mental health pre and during COVID. Because it didn't come out of nowhere. These video conferencing tools existed before COVID. Were they being used in mental health? We also wanted to know directly from our patients and carers and staff, so in the 3 South London mental health trusts, what was their experience? And then thirdly, we were aware that other service directors and also organisations in South London were already beginning to do their own evaluation of the impact of remote consultations. So we wanted to, what we ended up calling is do an evaluation of evaluations. So what does this look like in practice? So you'll see the evidence review, over 1,000 citations were reviewed for the pre-COVID literature, and during COVID with 77 relevant papers. So we're feeling we're coming from a very robust evidence base. We're really proud that we managed to engage with 6,000 patients and 700 staff across a full range of clinical services. And with the evaluation of evaluations, we included 32 projects, and actually colleagues from North London also wanted to be included in this work, so 10 of those came from North London. So I'm going to give you some of our, a snapshot of our findings, and there is a full report on our website, and Stuart's going to give you much more of a hands-on, this is what's actually happening in practice. So what did we find across these 3 work streams? So first of all, we wanted to know, was it even acceptable? You know, we've had a lot of discussion that patients definitely want this. Well, was it? Was it actually acceptable to be offering a remote service? And yes, certainly all the evidence from all the work streams said, yes, it is. It is acceptable, at least in the short term. And one of the things I'll do throughout the presentation is draw out anything on video. So what we do know is the level of satisfactions may be higher with video calls. Again, throughout everything that I'm saying, we do know there's a non-response bias. And that's a really key caveat. There are people we don't know about. So there are people that we haven't been able to reach. And that's also the research, remember. The research is not evidencing those people. So convenience, I think it probably, people will almost definitely jump to the conclusion, yes, of course it's more convenient. You don't have to travel. You don't have to pay for actually attending a hospital appointment. There's, expensive hospital car parks, etc. So yes, of course, there was that, we did find that finding that it is convenient for time and for travel. However, that's got to be balanced with, there's so much evidence to say that there are difficulties around computer literacy. And interesting, it's different, it's remote monitoring, but I don't necessarily think it is as easy as we think it is for patients to input data into remote monitoring devices. And that's the same for offering a remote consultation. And what was interesting, that the staff and patients often mirrored the same results, so that staff were finding meeting etiquette difficult, the same way as some of the patients were. And also privacy. The staff were working from home. The privacy of being able to operate in that home environment alongside the patients also had the issue around privacy. So if I move on to the Therapeutic Alliance, obviously there's absolutely no point in offering a remote consultation if you can't develop a therapeutic alliance. And again, there is some suggestion that it's much more easily developed with video conferencing as opposed to telephone. There is also evidence both ways, and it is slightly frustrating because we can't stand up and say we have the solution, and we do need to take on board all those literature, all those patient surveys and staff surveys. There is evidence to say that some clinicians did find it difficult to make a therapeutic alliance. But then there are also some that found that it was easier. So a lot of our work, you'll see towards the end of the slides, is we're saying there needs to be more research in this area. Cost effectiveness. I think without reading through it all, I would say the verdict's still out. We don't know that it is cost effective. In rural areas, almost definitely yes. The travel time, etc., is going to be a really major factor on whether telepsychiatry is actually something that should be cost effective and we should be offering. So again, more evidence needs to be gathered to know whether it is truly cost effective. In terms of commonalities across our work streams, in terms of exclusion, so much has been said this morning about exclusion. And yes, again, we have the same. There's not the evidence. So the research studies, the papers published, our patient and staff surveys, one of the trusts went the extra mile to actually contact older adults, particularly by telephone, to try and make sure, because they could see that they were not answering the online survey. But even so, the numbers were very small. So we really don't know the preferences of older adults at the moment. And I think, Stuart might be able to touch a little bit more on that, but that's a work that needs to be developed. We also, interestingly enough, of course, when you're an inpatient in a mental health service, you would normally see your consultant. Was this offered? Was video offered? And there's a lack of knowledge around that area as well. And children and young people. So what we want to give a very clear message is that we just don't have the evidence. And so sometimes I hear statements being made by quite senior people, particularly within the NHS, saying, it works, get on with it. We feel quite strongly you don't yet have the evidence. Yeah, we're gathering evidence, and you'll see that from Stuart's presentation. So my final slide is our research and evidence gaps. So I'm not going to read them all out because I've alluded to some of these already. But I think the change over time, and again, Stuart's going to tell us a little bit about that. He's got some data that shows us the change over time, and that's going to be really important. That blended option, patient choice blended option, how does that impact? And just generally understanding why people make the choices they make and being sure that they're given the choice in the first place. So, Stuart, I'm going to hand over to you.
Great, thank you very much, Eileen. Okay, so I'm going to talk a bit about our experience. So I'm from South West London, St George's, one of the 3 mental health trusts that we're working with, Eileen, in the Academic Health Science Network, which was a really fantastic kind of programme, and it's brilliant to be part of it. So I'm going to talk about kind of what we did with video during this time, and going back in time, in January 2020, We weren't doing any video at all. We'd tried to roll it out. We'd tried to use Skype for Business in 2016, and we just didn't get the uptake, despite getting really good feedback at the time. So in January, apart from a handful of our teams that were using it, and that was for our deaf services, we have a mental health deaf team that really valued video, we just weren't really able to get going with this. And then LHIS England allowed some free licenses for Attend Anywhere. We quite liked that, so we jumped on that bandwagon and we rolled with that. So we decided to roll out Attend Anywhere. To call it a rollout and a pilot, I think is slightly disingenuous, but it wasn't a pilot. We just pushed it out across the trust. We signed up clinicians without asking them. We set up all our reception areas, mimicking our existing kind of footprint, really expecting, with this virus on the doorstep, we wanted to have an alternative up and running, and we wanted to be able to offer video in addition to telephone. So we were really quite focused on getting everything up and running. So actually, by the time March came and the first lockdown came, we were ready to go with all of our clinicians signed up to Attend Anywhere. We did a survey of Attend Anywhere between June and August, and 929 patients gave us feedback, which was about a 10% response rate, so pretty good. And, you know, headlines, we've got a lot of data. But effectively, when we asked people, and this is despite 25% of people experienced problems with the video and audio feed at the time, because I don't know if any other people used Attend Anywhere in the early stages. Because it was rolled out so rapidly, the platform was quite unstable. So it wasn't always the best, but despite 25% of people saying they had video, audio problems, 94% said, yes, I'll definitely use it again, and really, really positive feedback overall. Patients told us that they saved on average £5 in travel costs attending the appointment using video, and about 40 minutes in time. Obviously, we're not a rural trust, we're a kind of a London mental health trust, so often people don't have to travel quite so far. So that was kind of Attend Anywhere. And actually, if you look at our use of video over time, we haven't really been doing anything with it over the last year, but it's carrying on being used at the same rates that it was in the early stages. So as I say, going back in January, we were kind of 0.1%. By April, we're hitting about 12%, and we, you know, maxed to about 20% of video consultation, of all consultations being video in January, February 2021, and that was sort of the highest rate of use. But you can see that over time, people still want to use it, clinicians are still using it. We've gone beyond Attend Anywhere. We're using Attend Anywhere for one-to-one and small groups, and we're using Microsoft Teams for our larger therapy groups because we felt the platform wasn't suitable, and we've done clinical safety cases for both systems. So they're our sort of our main offering for using video. We obviously had, you know, questions, or we have questions over who's using the video, who's choosing to use video. So this graph shows percentage contact type by age range. Age is the most consistent factor in determining who chooses to use video. So you can see that if you're in a CAM service all the way to the left, so the blue is video consultations, you can see that you're more likely to use, as a proportion of contacts, to use video compared to our older adult services all the way to the right, which are far more likely to choose telephone, actually. The orange bar represents face-to-face contact as a proportion. So age is absolutely is the biggest factor that we found in deciding kind of how who chooses to use video consultations. I'm not going to attempt to explain mental health clustering if you don't know what mental health clustering is. It has its uses. So you know, I did try and do this as diagnosis, but there's just too many columns, so it's easier doing it by clustering. So again, blue is proportion of video, green is other, and that's mainly telephone, and the orange bit in the middle is face-to-face. So you can see that the clusters that are most likely to use videos are clusters 1 and 6. Now, these are people with mild anxiety, mild depression. Cluster 6 is quite severe anxiety disorders, often OCD, people with contamination fears. So it's not surprising that actually they're choosing to use video. So I think we have to be mindful of actually sometimes offering things that might not be in their best interests, because I think there's a degree of avoidance there that we have to be quite cautious about. So high use is there. And, with the eye of faith, I can sort of see that as depression gets more severe, the less likely you are to use video based on the data that we've collected. Low rates in psychosis, apart from people with first presentation of psychosis, but again, they tend to be younger. So our first episode psychosis tend to be younger, and again, very low rates of video in our people with cognitive impairment. So that's what we've seen. One of the great things about being part of this program is sharing ideas. So we stole this from SLAM. SLAM developed a decision tree. So how do our teams decide who to offer video to, as opposed to face-to-face in a safe way? And we wanted to adopt a blended approach. We wanted to give our patients choice. We didn't want people to feel they didn't have a choice in how they wanted to engage with us, and we needed to support our clinicians with that. So we developed our own decision support tool, which has gone across the teams, and we've also adjusted some of our key dashboards and sort of kind of KPIs to allow video to be a proxy for face-to-face for some of our contacts, because in the early stages they weren't seen as the same. So we had discussions around that. So now this is up and running, and actually all of this stuff is available to share on the HIN website. So if people also want to steal some of SLAM's ideas. All the way through, we've talked about outcomes and evidence, and obviously working with Eileen and the team, it was thinking about, well, how do we know that we're as effective using this high rates of video compared to how we were before? So we had a kind of a hunch that we were doing all right, and we saw that with our IAPT recovery rate. So our IAPT services were heavily using video, and despite that, the recovery rates, which are sort of nationally determined, didn't change, so they're the same. So that was good, suggesting that we weren't doing any harm. And also, we looked at other satisfaction scores for our community teams, and they continued to do well as well. But we wanted more than that, and so this doesn't particularly project very well, but we've been working on our dashboard. So what we're now able to do is to cut our dashboard based on outcomes against sort of contact type. So in mental health, our main outcome measure that we use as a clinician-rated outcome measure is HONOS. So this is one way of viewing that, but perhaps a better way of viewing it would be in this graph here. So really what this tells me is that when we look at HONOS scores between sort of first and kind of last rating and the difference in change, so the greater the change, the greater the difference, the better, we can really see that when we cut it according to consultation type, there's not a huge amount of difference, a huge amount of variation between video, face-to-face or telephone. So certainly there in item 6, so that's a measure of psychosis, so delusions really and hallucinations, there doesn't seem to be any difference at all. Whereas in perhaps item 7, where that's a rating of depression, you might think that on average face-to-face is probably better than video, which is better than telephone. So this is just work in progress for us. We just want to be able to track our data as we move forward, just so that we can really start to kind of ask that question of ourselves, really, whether or not it's having a detrimental effect on our outcomes. And so far, we don't think it is. Thank you very much.